Hello, everybody. Good afternoon. This is Nurse Eunice with Florida Training Academy, and we're going to get started in about 10 seconds. Today's video is going to be a lecture on oxygen therapy, and we'll also be completing a quiz afterwards. So go ahead and get your pen and paper. Let's prepare to learn a lot. And for those of you all who are already in the chats, hello, hello, hello. For the first half during the lecture, I won't be monitoring the chats. However, I will monitor the chats whether you're on Facebook, YouTube, or X. I'll monitor the chats once we actually begin our quiz. So let us begin, everybody. So here's my disclaimer. This video is for educational purposes only. While I strive to provide the most accurate information that is based on current research, standards can change. Therefore, if you have any specific questions or concerns, I ask that you consult your facilities director and or nurse educator. One of the first reasons or conditions in which a patient could need oxygen therapy could be COPD. And so here's a description. Patients with COPD often have difficulty maintaining adequate oxygen levels due to obstructed airflow because the lungs become damaged or clogged with phlegm, mucus, or fluid. And so when you look at the airway in the image, you can see that it's filled with some type of mucus or green fluid. Some of the signs and symptoms of COPD could be shortness of breath, dry cough, a cough that brings up mucus, and also chest tightness and wheezing. And some of the causes could be smoking, pollution, and genetics. So that one was COPD. Pneumonia is another lung condition which could possibly require oxygen therapy for your patients. So those with pneumonia is an infection in the lungs, so it can be caused by bacteria, viruses, or fungi. And the bacterial pneumonia is usually the most severe. And the viral pneumonia can sometimes just resolve on its own. It depends on your patient. If your patient's elderly or if they have a weakened immune system, then well, we're going to have to give them some antibiotics or an antiviral treatment in order to kill whatever is growing in their lungs. And then pneumonia can affect one or both lungs. So COPD, chronic, that's going to affect both lungs. Pneumonia can be one or two lungs. Asthma. Asthma is a condition in which a person's airway becomes inflamed, narrow, and swell, and it can also cause mucus production. It makes it difficult for that person to breathe. Severe asthma attacks can lead to reduced oxygen levels, difficulty breathing, chest pain, and wheezing. So, some of the causes of asthma or triggers could be pollution, smoking, bacteria, genetics, so it can run in the family, pets, their fur, the dander, household chemicals, and dust. And so, as a CNA or as a caregiver, we ask that you don't fan any items in the patient's room because that can actually lead to particles being exposed to the air. Your patient can breathe that in, they can have an asthma attack. We also ask that you don't wear any strong fragrances because that can trigger an asthma attack too. Heart failure. So when the heart fails, remember the heart, it pumps, it circulates oxygenated blood. But when someone's heart is failing, the cardiac output is reduced. So if there's a lower output, there's going to be lower amounts of circulating oxygen in the blood. And so that person can have chest pain, shortness of breath, dizziness or lightheadedness, the swelling in the legs, sudden weight gain, and sudden fatigue or weakness. And so in order to help their body, since they don't have enough blood flow circulating to carry the oxygen, they might also require supplemental oxygen. And this is a biggie, your post-surgical or your recovery patients. So patients recovering from surgery, especially those with pre-existing respiratory conditions, may require oxygen to ensure proper tissue oxygenation. So maybe they were sedated or intubated during the actual surgery, and then afterwards, it may take them a while to recover, to start breathing again on their own at a normal rate. And so we may have to give something called Narcan to reverse the effects of the anesthesia. But an acronym that I want you to remember, anytime you have a person who is post-op, who is having problems with breathing, I want you to blame anesthesia. And so the mnemonic anesthesia stands for atelectasis or poor air exchange. You're not taking those deep breaths in and out, which is why we usually ask that the patient's using a center spirometer. Pneumonia, of course, pneumonia doesn't start with an N, but just bear with us. It's my mnemonic. Edema, shunting, meaning that the oxygen is going to a different area. Terrible lung disease, hemothorax. So that means that there is blood in the lung. Embolism, as in pulmonary embolism or blood clot. Spasm, yes, they can have bronchospasms. They can have infection. And for this one, it says infections, pneumonia, but infection could be bronchitis. It could be that pandemic that we just recovered from, where I don't want to say the name because if I do, my video may be flagged by YouTube. And then it could also be air or a pneumothorax. So if your patient's having breathing problems after surgery, I want you to blame anesthesia and start thinking of those causative reasons. And if we can find the reason, we can fix their respiratory issues. Acute respiratory distress syndrome or ARDS. You'll hear about this a lot with kids, but it can occur when fluid builds up in the tiny elastic air sacs or alveoli in the lungs. And when you look at this image, the lungs are not clear. The lungs have fluid in them. So as a caregiver, you don't have a chest x-ray right there. So anytime your patient short of breath, I want you to automatically assume they have fluid in their lungs. And of course, we know we're going to sit them up and we're going to apply the correct oxygen device. If you're a CNA, CNAs do not turn up the flow or the dial on oxygens. Oxygen's a drug. You cannot change the dial. But what you can do instead is you can notify that nurse, make sure you actually check the oxygen saturation and the other vital signs. And if something has disconnected or if the patient doesn't have their device on correctly, you can fix that. So there are things you can do if you're not a nurse or a respiratory therapist. Moving right along, another condition in which a patient might require oxygen would be anemia. And so anemia or low hemoglobin levels reduce the blood's oxygen carrying capacity, sometimes necessitating oxygen therapy. So remember, the red blood cells carry or they're attached to oxygen. And so if they have low levels of red blood cells, their oxygen saturations can also be low. Carbon monoxide poisoning. So carbon monoxide is a tasteless and odorless gas. So sometimes people don't even know that they're exposed to it, and they can be exposed to it by their gas stoves, different heating sources, or from their vehicle. And it is critical whenever we have a patient who has carbon monoxide poisoning, the way to displace the carbon monoxide is to actually use high flow oxygen. And here's an example. This is a hyperbaric oxygen chamber. And so we can use a mask for some patients, but if a person has severe carbon monoxide poisoning, they may have to go into a hyperbaric chamber that is pressurized with oxygen. And now we get to the different types of oxygen delivery devices. And for those of you who are just tuning in, we just talked about some of the reasons that a patient may need oxygen. Now we'll talk about the different devices. And at the very end, we'll do a practice quiz. And so I won't be able to monitor the chat until I get through with the lecture. And so types of different oxygen delivery devices. Oxygen delivery systems are classified into low flow and high flow devices, depending on their ability to meet the patient's inspiratory flow demands. So how much help do you need? Do you need extra oxygen or do you need more ventilation, more assistance whenever you're breathing? So one of the most common devices is a nasal cannula. It's pretty comfortable and it's easy to use. If you're taking notes, I want you to write this down. The flow rate for oxygen, how far can we turn the dial? It's usually 1 to 6 liters per minute. The FiO2, or the fraction of inspired oxygen, that's the concentration of the oxygen in the gas mixture. So the FiO2 for a nasal cannula is usually 24 to 44%. So this is low flow. It's comfortable and is suitable for patients with mild hypoxemia or low blood oxygen levels. A Venturi mask, and you'll see what it looks like on the next slide, but a Venturi mask, usually if it's less than 5 liters, we consider it low flow. So a Venturi mask, based on the flow and the patient's needs, it can be low flow or high flow, but you can start off at 4 liters per minute. The FiO2 is 24 up to 60%, and this is going to be important for when you take your quiz later. The Venturi mask provides a precise FiO2 and is useful for patients with COPD who require controlled oxygen therapy to prevent CO2 retention. And so they can actually retain the carbon dioxide, which will make their blood acidotic. So they need oxygen. Otherwise, it's going to be displaced by something that's going to cause their bloodstream to become poisonous. And we'll call that like respiratory acidosis. And here's an example of a Venturi mask. And so based on the adapters or the valves, your respiratory therapist can show you, or your nurse can show you how to insert the different valves into the mask. But the smaller range is 24%, goes all the way up to 60%. So if the person is only needing a low flow amount of oxygen, you would use the lower FiO2. Are high flow oxygen devices. So when your patients need a higher, more consistent quantity of oxygen, because they require more assistance with breathing, that's when we start using the other mask. And so one of the masks that we can use is a simple face mask. The flow rate for this one is 5 to 10 liters per minute. It gives approximately 40 to 60% of FiO2 or oxygen, and it's for moderate oxygen needs. And if a person requires higher flow rates to prevent the rebreathing of CO2. So it has a strap. Sometimes that strap can cause irritation along the ear. So if your patient does have a mask on, when you're doing your skin checks, also check their ears because it can become irritated. You can put a piece of gauze there or just change the position of the strap. So yes, we're trying to protect their airway, but we also have to protect their skin too. The partial rebreather mask. A partial rebreather mask delivers oxygen therapy for people who need higher concentrations of oxygen, but don't need help breathing. In other words, they can take breaths in and out. They just need a higher concentration of oxygen when they do take those breaths in. And so the flow rate for this is going to be 10 to 15 liters per minute. You want to turn that dial as high as it can go, depending on your patient's presentation. And so the FiO2, or how the percentage of oxygen that the person will be breathing in, would be 50 to 70%. And the usage, it allows some rebreathing of exhaled gases. There's a reservoir bag at the end, and it's going to increase the amount of oxygen available. And the image is on the next slide. So it's your partial non-rebreather mask. The patient can breathe in some of the exhaled gases or air, and it has a reservoir bag. In this image, this is absolutely incorrect. This is going to be connected to oxygen. So if it's connected to oxygen, that reservoir bag at the end should not be deflated. It should be inflated. So you connect it, you turn the flow meter up to 10 to 15 liters, that bag is going to inflate, and that ensures that your patient is receiving 50 to 70% FiO2. If the bag is deflated, you need to be checking how many liters of oxygen you have the patient on. The non-rebreather is very common, especially in your critical care and your telemetry floors. We may start off with a nasal cannula, but depending on how the patient's presenting, we may have to go up to the non-rebreather mask. So the non-rebreather is similar to the last mask that I just showed you. However, it does not allow any rebreathing of exhaled gases. So this person's getting almost 100% oxygen. It is high flow. So this one is for emergencies. And you can wean the oxygen up So you can go up, you can go down. If there's an emergency, I don't want to see you putting your patient on 6 liters of oxygen via nasal cannula. First of all, it's going to be very uncomfortable. You want to go to the next device, whether it's a partial non-rebreather or a partial rebreather or a non-rebreather. We can always titrate or work our way back down once we stabilize that patient. And what I'm telling you is it's good for most of your hospitals. When there's an emergency, sometimes your doctor's not going to answer the phone right away. So if your doctor's not answering the phone, but your patient is short of breath, O2 sats low, you're not sometimes waiting on an order. You're applying the correct oxygen device and then letting the doctor know what you did once you have him or her on the phone. So in most of our facilities, at no point do we wait until the doctor returns our phone call and our patient is in distress while we're waiting on an order. We can go ahead and go from the nasal cannula to the next device, if we needed to stabilize our residents or our patient's oxygen level. This is an example of a non-rebreather. So this one has the expiration valves on it. So again, this does not allow the patient to breathe in any outside air. So it lets them expel their CO2, but it doesn't allow them to breathe in any outside air. They're getting close to 100% oxygen, and this is what's needed for someone who is critical. There's also a new device. It's a little bit newer. It's called the high flow nasal cannula. And so this is like this power packed nasal cannula where you can actually have up to 60 liters per minute of oxygen. I know that's a lot of oxygen, but it too delivers up to 100% FiO2. The benefits is that it's a little more comfortable, but this person is, they're pretty bad if they have this one on. So it provides heated and humidified oxygen. It's suitable for patients with moderate to severe respiratory distress, and it improves comfort and mucociliary clearance. In other words, it allows them to cough up their mucus. So sometimes with the mask, they can't really cough up the mucus or it gets inside of the mask. And of course, as a caregiver, we have to clean that up. And this is an example of a high flow nasal cannula. Now we get to our CPAPs and our BiPAPs. So non-invasive positive pressure ventilation. So this means that we have a device that we're going to put onto a patient's face, and this actually is pressurized. So it's going to be pushing oxygen in so that the person gets better lung expansion. And so some of those for sleep apnea, we have CPAP, which is continuous positive airway pressure. And then we have BiPAP, which is bi-level positive airway pressure. And so the flow rate with the BiPAP could be variable. And also with the CPAP. So it's pretty much going to be based on what the patient's needs. And of course, the pulmonologist or the doctor who specializes in respiratory conditions will order the settings and the machine will be set. And as long as the patient wears it, they're going to receive whatever the doctor has ordered. It can deliver up to 100% FiO2. And notice how I keep saying up to 100% FiO2. You all, we rarely want a person with oxygen therapy whose O2 sats are at 100% because that can actually be bad for them. There is something called hyper or oxygen toxicity, and that's when they have too much oxygen. So usually for our adults, we like their O2 levels to be 94 to like 99%. That will be the goal. We rarely want someone on oxygen therapy to be at 100%. So the CPAPs and the BiPAPs are for patients with respiratory failure, sleep apnea, exacerbations of COPD, and it supports ventilation by maintaining positive airway pressure. So it's pushing in oxygen. And as long as they have a tight cylinder mask, that maintains the pressure. And here are some examples. So when you see a patient with a mask that they have to put on at bedtime, it could be the CPAP or the BiPAP. And if you're in home care or you're in a nursing home type facility, your job is to make sure the patient has it on at night. In the hospital, sometimes we have respiratory therapists who will assist us. If the respiratory therapist isn't there, then of course it would be your job to help assist the patient with their CPAP and their BiPAP. For our critical patients, we have mechanical ventilations or mechanical ventilators. And so for these are for patients who require full support, and it's used in intensive care settings. It can also be used in home care settings. Like if we know that we cannot wean a patient off of the vent, well, then they can go home with their vent, but they're usually also going to have an artificial airway, referred to a tracheostomy. So if a person's on a mechanical ventilator, it's of course going to be supervised by a doctor, and it's going to provide concisely controlled therapy based on the patient's requirements. And in the next picture, I have an image. This is somebody who has an oral airway. So we'll call this an endotracheal tube. So the endotracheal tube is actually going into the mouth, down into the trachea. And so it is cuffed for most of the adults. And it actually, we can actually, how should I say this? I apologize. You want to be checking the bulb to make sure that it's actually inflated, because if it is deflated, that means that maybe the endotracheal tube can become dislodged. So that will be something you want to be looking at every time you go in and you check your patient. But on this particular image, the person has an endotracheal tube that's connected to a mechanical ventilator, and it has settings. It will set like the respiration rate. So maybe the doctor wants this person breathing 16 breaths per minute, and they want the FiO2 at 95%. The machine will take care of all of that. And our job as caregivers is to make sure that that tube doesn't become dislodged, and that we suction that patient because they're unable to clear their mucus or their secretions. And then one other thing, if you look at the image and look at the positioning, it is rare that we have somebody who is intubated flat. We may have them flat or in the supine position while we are positioning them, repositioning them. But as soon as we're done, we have to get them up to a semi-fallish position. We normally don't sit them all the way up. You don't want them in a 90-degree position for too long, because that can actually cause them to get a bed sore. So semi-fallers is more comfortable. It allows them better clearance whenever they're breathing, and it helps promote their respiratory conditions. Our key considerations before we get to our quiz is monitoring. You want to regularly monitor oxygen saturations using a pulse oximetry. The target SpO2 or the O2 level depends on a patient's condition. So if a person has COPD, remember they can retain carbon dioxide. So we don't use a whole bunch of oxygen with them. Our oxygen saturation, we're good if they are between 88 and 92%. And I know 88% O2 sat seems low, but we need to keep their drive. We need to actually, again, too much oxygen for them is a bad thing. So 88 to 92%, as long as they're not in distress, we're okay with that. In an emergency, based on what your doctor says, we can go up a little bit on the oxygen for those with COPD, but please let your doctor decide. And then for the other patients, as I already stated, usually we like an O2 sat of anywhere from 94 to 98%. So if you have them on oxygen therapy and they're sat at 100%, you probably want to be cutting back some of that oxygen. Humidification is another key consideration. Humidification is often required for flow rates above 4 liters per minute to prevent drying of the mucosa. And then patient comfort and safety, ensure proper fit and comfort of oxygen delivery device, and educate patients about the importance of maintaining their oxygen therapy as prescribed. So we do education all day long. And this is an example of the pulse oximeter. You may refer to it as a pulse ox, but it is the electronic device that measures the oxygen saturation carried in the red blood cells. There was a study that was recently out, and it just reminds us that if you have somebody who is of a darker complexion, sometimes those machines are not reading as well because of our complexion. So if your patient, isn't presenting well, they're telling you they're short of breath, but this machine is saying everything's good. If they're brown skin, everything may not be good. They may need an ABG or some other testing or a more invasive way to monitor the oxygen levels. Oh, and then let me go back. Also, if a patient has on fingernail polish, remove the fingernail polish. If their hands are cold, you want to warm their hands. And positioning could also affect the reading. So if any of those happen, you can switch hands. You can probably find a different type of device. They have some that you can use like an adhesive, like a Band-Aid to fit on the fingertip. And worst case scenario, worst case scenario, we can use a toe. All right, so by understanding the various reasons for oxygen therapy and the appropriate use of different oxygen delivery devices, you can effectively support patient care and improve outcomes in individuals with respiratory needs. And I love this image because patients are so eager to get out of the hospital. They start feeling better. Where if they've received oxygen in the hospital, especially for a prolonged length of time, they have to actually walk without desatting or desaturation, meaning that their levels drop. If they start walking and their O2 levels decrease, that could be an indication that they need to go home with oxygen. So usually before someone is discharged, we walk them with the pulse oximeter. We do their vital signs before the walk and after the walk to see if their O2 levels decrease any. And if so, then unfortunately, they go home with oxygen until their strength improves. All right, so now I'm in the chats. Let's see what you all have. All right, so question number 1, team. Which condition is most likely to require oxygen therapy? Is it hypertension, diabetes, COPD, or osteoporosis? Great job, Ruth and Chrissy and Flossie and Shamika. Yes, it is COPD. So COPD often results in chronic hypoxemia due to obstructed airflow, making oxygen therapy necessary. The next question, what is the goal of oxygen therapy? Is it to increase blood pressure, improve oxygenation, reduce heart rate, or lower blood sugar levels? Why are we putting these devices on our patients? And Cassandra and Erie, great job. Yes, H. Will, that was C. And yes, for number 2, I see the correct responses. It is B as in boy. So whenever you're putting oxygen on someone, the end result should be that we're going to have an increase in their oxygen levels, and we're going to prevent hypoxemia. Number 3, which device delivers the lowest concentration of oxygen? Nasal cannula, non-rebreather mask, simple face mask, or Venturi mask? Great job, team. Yes, the correct response for this one is going to be A. The nasal cannula delivers 24 up to 44% oxygen, and it is one of the lowest oxygen delivery devices in comparison to the others. And don't forget, the highest amount of oxygen or the flow rate is 6 liters. If you put more than 6 liters on a nasal cannula, it's going to be very uncomfortable, and you just need to go ahead and use a different device. Number 4, what is the typical flow rate for a simple face mask? Is it 1 to 2 liters per minute, 2 to 4 liters per minute, 5 to 10 liters per minute, or 10 to 15 liters per minute? What is the flow rate for a simple face mask? We'll be revealing the answer in 3, 2, and for this one, I saw a lot of you all choose 2 to 4, but this is the next step beyond the nasal cannula. So don't forget, the nasal cannula can go up to 6. So for your simple mask, we can start at 5. So the simple mask typically delivers oxygen at flow rates of 5 to 10 liters per minute. Which oxygen delivery device is most suitable for patients with severe hypoxemia? nasal cannula, simple face mask, non-rebreather mask, or Venturi mask? I think I see some correct answers. Yes, Katie Ann. Yes, Diamond. Yes, Shamika. Yes, Karen. That would be the non-rebreather mask because it can deliver up to 100% and it is suitable for those who have severe hypoxemia. Why might a Venturi mask be preferred for patients with COPD? It provides humidified air. It allows precise control of FiO2. It is the most comfortable option. It is the least expensive option. And if you recall, I told you to take notes when we were talking about COPD. Yes, Flossie, Ruth, and Cassandra, you are correct. Alex and Lynn, yes. So it provides a precise control of FiO2, which is crucial in patients with COPD because they can retain the carbon dioxide. Question number 7. What is the maximum flow rate for a nasal cannula? I've said this like 20 times, so you have to get this one right. The maximum flow rate for a nasal cannula. Yes, Ruth, Shasha, Shamika, Erie, Cassandra, you all have the correct response, which is D. So 6 liters per minute is the max for nasal cannula therapy. Number 8, which of the following conditions may not typically require oxygen therapy? Asthma, pneumonia, hyperthyroidism, or anemia? Yes, Alex and Yemi. Yes, you all have the correct response. It would be hyperthyroidism. That typically does not result in hypoxemia or low oxygen levels. Meanwhile, the others might. Number 9, what is a common complication of long-term oxygen therapy? Hypertension, oxygen toxicity, diabetes, or dehydration? Great job, team. Great job. So if you chose B, you are absolutely correct. So long-term high concentration oxygen therapy can lead to oxygen toxicity, which can damage the lungs. Some of the most common symptoms that people are going to be complaining of is like headache. It's like, oh my God, I'm on this oxygen, my head hurts. But they can start having visual changes. Worse, some of the worst symptoms or conditions that could occur would be oxygen toxicity, could be seizures. They can start having muscle twitching and shortness of breath, believe it or not. So having too much oxygen can cause you to have respiratory distress, especially in somebody with COPD who needs carbon dioxide. They need that drive to help them breathe in oxygen. Number 10, which condition is high flow, for which condition, is high flow nasal cannula most appropriate? Is it mild hypoxemia, severe respiratory distress, hypertension, or mild dehydration? So remember, this was the high powered one that went up to like 60, I think it was 60 liters per minute. So who would need the high flow nasal cannula? Revealing the answer in 3, 2, and yes, everybody. Yes. So it's going to be those who have severe respiratory distress. Number 11, why is humidification often necessary for oxygen therapy above 4 liters per minute? Is it to prevent the drying of the mucosa, to increase the FiO2, to enhance oxygen absorption, or to cool the oxygen? Let's see. Why do we humidify? Yes, Flossie. Yes, Yemi. It prevents the drying of the mucosa. So, yes, humidification prevents the drying and irritation of the respiratory mucosa when it's at higher rates. Remember, oxygen is going to dry your patient's airway, so it can cause irritation. It can also cause some bleeding to some discomfort. Number 12, which device is most effective for delivering a consistent and precise oxygen concentration? Is it room air, nasal cannula, Venturi mask, or partial rebreather mask? And we discussed this during the lecture. Precise oxygen concentration. This is the one that had the different color valves, if that helps. Precise. The nasal cannula isn't precise because your patients are, little boogers. They take the nasal cannula out their mouth and they like put it in their out their nose and put it in their mouth sometimes. So they're just put the prongs on top of their noses. So that one would not give precise oxygen concentration. So this one was tricky, you all. Here's the response. It is C, it's the Venturi mask. It is designed to deliver precise and consistent FiO2. Remember, it has the different color valves. And so if I want my patient to receive 28%, I will get the valve that's marked 28%. I will put it on the mask, attach it to it, and that would ensure that our person is receiving 28% FiO2. This one's tricky. What flow rate and FiO2 are typically associated with a partial rebreather mask? Is it 1 to 4 liters per minute and 24 to 30% FiO2? Is it 5 to 10 liters per minute and 40 to 60% FiO2? Remember, the partial rebreather mask is the mask that you put on before the person gets a non-rebreather. So is it 10 to 15 liters per minute at 90 to 100% FiO2, or 10 to 15 liters per minute with 50 to 70% FiO2? I think Chrissy and Lynn, I think you all have it. I think you have it. So for this one, everybody, I see C's, I see D's. I tricked you. For this one, it is D. So let's go back. It is 10 to 15 liters per minute, but it does not deliver up to 100% oxygen. That would be the non-rebreather. So for this one, it would be D. So 50 to 70% FiO2 at 10 to 15 liters per minute. And if anyone says, Nurse Eunice doesn't know what she's talking about, well, go to opencriticalcare.org, a source that I trust, and this is directly from their website, okay? Number 14, which condition can be exacerbated by improper use of high concentration oxygen therapy in COPD patients? Is it respiratory acidosis, respiratory alkalosis, hyperventilation, or metabolic alkalosis? What can we exacerbate by improper use of high concentration oxygen? Flossie and Yimmy, you remembered, you got it. Too much oxygen can make them acidotic. So it is going to be A. They can have respiratory acidosis. So excessive oxygen can suppress the respiratory drive in COPD patients, leading to CO2 retention and respiratory acidosis. Great job. Number 15, if a patient's SpO2 remains low despite using a nasal cannula at 6 liters per minute, what should the next step be? Decrease the flow rate, wait for the respiratory therapist to give you an order, switch to a non-rebreather mask, Discontinue oxygen therapy. Your patient has a low O2 sat. What are you going to do? Yes, Flossie, you have it. We're not waiting for anybody. I cannot call that doctor and be like, you know what? I was waiting for the respiratory therapist, so I didn't do anything. I left a nasal cannula on the patient. It wasn't even working, but I was just waiting for you to call me back. No, absolutely not. If one device isn't working, you go ahead and switch the device to the higher level and you call that doctor or the respiratory therapist and let them know what you did. And I'm speaking from a nurse. If you are a CNA, this would not be your job duty. However, at least you kind of know what's happening when you're in the field, when the nurse is telling you to, hey, go get this mask, or hey, sit this patient up. You're kind of understanding why we have to titrate, go up and go down with these different devices based on how our patients are presenting. Number 16, what is the primary advantage of using a high flow nasal cannula over a standard nasal cannula? A lower cost, provides heated and humidified oxygen, higher comfort, or easier to use? Yes, Target. Yes, Flossie. So this one is going to be B. I am so proud of you all. You did very well with this test. Number 17. How can you troubleshoot a non-rebreather mask that is not delivering adequate oxygenation? Is it A, check the oxygen flow rate, B, adjust the nasal prongs, C, remove the reservoir bag, or D, lower the oxygen tank pressure? Remember, I talked about that bag, and if that bag wasn't inflated, I needed you to troubleshoot. So, what are you troubleshooting if that bag is not inflated? With the non rebreather mask or also with the partial rebreather mask? What do you need to do? And I'm revealing the correct answer. Target. And 3, 2, and 1. Yes, you all, you don't ever want to remove the reservoir bag. The reservoir bag should be filled with oxygen. So if it's not filling, it's more than likely because someone in nursing school taught you to be afraid of giving someone too much oxygen, but right now it's an emergency. So you can't have a mask and your patient on 2 liters per minute. If you have to put a mask on someone, 10 to 15 liters, that's going to ensure that the bag is going to be, especially the reservoir bag, is going to be filled with 100% oxygen or close to it. And when they breathe in, they're going to inhale the proper amount of oxygen. So if it has a reservoir bag, you need to make sure that your valve or that your flow rate is 10 to 15 liters per minute. Whatever the max is, just max it out. What is the potential side effect of prolonged oxygen therapy without humidification? Hypotension, nosebleeds, increased mucus production, or hyperglycemia? Hmm. What do you think, team? Shamika says B. Lynn says B. Anyone else? Target says A. Creasy says C. Oh my God, you all are everywhere. So because it dries out the airways, you all, it's going to be nosebleed. So the dryness of oxygen can dry out the nasal passages. It can also dry out their oral airway, their mouth, and it can cause irritation. And in some instances, the dryness can result in nosebleeds, especially if their nose is irritated. You know what we do when our nose is irritated. We don't leave it alone. We're going to be up there. We're going to be doing some stuff. So not only is it irritated, I've now scratched it, and that's going to cause some bloody drainage, aka a nosebleed, which is why we really recommend humidified oxygen therapy for your patients. Number 19, which oxygen device is used to provide continuous positive airway pressure in patients with sleep apnea? Nasal cannula, simple face mask, a CPAP, or a non-rebreather mask? In target, the nosebleed is because the nostrils or the airway is dry. And so don't forget that the respiratory system includes the nose, it includes the mouth. And so when we have oxygen on a patient for a prolonged amount of time that's not humidified, it's going to dry out their airway, their passages, and that's going to lead to irritation that can then lead to the nosebleed. So I hope that explains it for you. And for this one, everybody, if you chose C, you are correct. So CPAP stands for continuous positive airway pressure. And we usually prescribe that for patients with sleep apnea. So they will put that on before they go to bed. Number 20, which oxygen delivery method is typically used during emergency resuscitation? Look, I tricked you. I didn't talk about this because you should have taken CPR. And if you haven't taken CPR, I have a video that has like 400,000 views that talks about CPR. So, which of these devices is typically used during an emergency? This person's in cardiac arrest. We're trying to resuscitate them. Is it going to be a nasal cannula, a simple face mask, a non-rebreather mask, or a bag mask device? Yes, you all are CPR certified. You're my peeps. Yes, so the correct response is going to be D. It is going to be the bag mask device. And whenever you're utilizing this device, you would also connect this to oxygen if you have it available. And then the reservoir bag will inflate, and you use the EC clamp technique. When you look at the mask, her two fingers, her thumb and her pointing finger, are making the C, and her remaining fingers are making the E, and they're along the jawline. Open up the airway, and you'd administer your 2 breaths after the person receives their 30 chest compressions. So it's 30 compressions followed by 2 breaths. Number 21, why might a patient experience headaches with high flow rates of oxygen therapy? Is it due to hyperventilation, oxygen toxicity, carbon monoxide buildup, or hypoglycemia? Yes, don't get tricked for this one. It is oxygen toxicity. So high flow rates of oxygen can lead to toxicity. We talked about the eye changes, but it can also cause headaches too. Number 22, in what scenario might a simple mask be preferred over a nasal cannula? For patients who require a higher concentration of oxygen than a nasal cannula can provide, when precise FiO2 is needed, for patients with claustrophobia, or for those who have long-term oxygen therapy at home. Yes, Barbara. Yes, yes, yes. So the correct response for this one is going to be A. So when you want to go from if your patient can tolerate it, you would go from the nasal cannula to the simple mask. But if they can't tolerate it, if like they're like doing really, really bad, we can go directly from the nasal cannula all the way up to the non-rebreather. So as the nurse, as the doctor, as the respiratory therapist, you can decide how fast you go from one device to another. Remember, once we stabilize the patient, we can always work our way back down to a nasal cannula. Number 23, what should be done if a patient using a Venturi mask has increased secretions? Do we want to decrease the flow rate, switch to a nasal cannula, suck the patient's airway, or increase the oxygen concentration? This person has increased secretions, but they have a mask on. What do you think the best intervention would be? All right, so we have increase the oxygen. We have, there we go. I see a lot of correct responses. The correct response would be C. So if the person starts, remember they have this mask on, and so they may be coughing, but they can't really clear their airway because the mask is preventing the mucus from coming out. So you would take the wand, the suction wand, and you would assist them with cleaning out their secretions. A lot of patients, once you show them how to use the wand and you have it within reach, they will go ahead and utilize it without you being present. But that would be how they could clear their airway. If you are using this wand, you don't want to be forceful, because especially with someone with dry airways or dry passages, if you remove the mask, you don't take the mask all the way off. You bring the mask over to the side so it's still flowing. You insert the yonker or the suction tube. So we still have oxygen flowing, but we have the suction tube off to the side. We can remove those secretions and allow the person to receive their oxygen. If you take the oxygen off, they're going to desaturate. So yes, you're clearing the secretions, but you still want them to be able to breathe in some oxygen. But if you're really rough with that wand, you're going to make their mouth bleed. So be gentle when you're cleaning their mouth. Number 24, what is the FiO2 range for a Venturi mask? And this is the one that has the different valves that allows a precise flow of oxygen. Is it A, 24 to 60%, B, 40 to 60%, C, 60 to 80%, or D, 80 to 100%? I think I saw the answer. I think H. Will and Jane have the correct responses. So yes, it is 24 to 60%. Remember, it has the various size valves. And if you want to deliver the lesser amount of oxygen, you would select the valve and connect it to the mask that says 24%. 25, which condition is not typically associated with a need for supplemental oxygen? Is it pneumonia, congestive heart failure, anemia, or hyperlipidemia? Flossie, Yemi, Ruth, I'm so proud of you. Target, Sola. Yes, everybody, hyperlipidemia. It doesn't affect the oxygenation. And so hyperlipidemia means that they have an increased amount of lipids or fat in their bloodstream, or high cholesterol levels. And so everybody, I appreciate you all so much. You all are wonderful. You're marvelous. I love working with you all. And if you haven't already liked the video, please do so. It helps us be found by other people, and also subscribe to our channel. And I will be back on here, I think, Wednesday, because I have a busy week this week. But thank you all for studying. Enjoy the rest of your holiday weekend. Target, you're welcome. And I don't know what video I need to create this week. So before I leave today, someone let me know what video you want to see. You all are so welcome. I appreciate you all too. Yes, Barbara, it was fun. And you all, this was Karen's idea. Karen wanted oxygen therapy, so it took me a few days, but I got it done. So let me know what video you want. I need 3 suggestions. Target, I don't understand your question. Which language? If I don't know if you want to use closed captioning and have this, I think YouTube actually lets you select different languages. So anyone, no ideals, no suggestions? All right, I'll monitor the chats. If you have a ideal for our upcoming video or our lecture, I'd love for you all to let me know. I'll be monitoring the chats for another 2 minutes. And for everybody else, you have a good night, and thank you for watching. Don't forget to like and subscribe. Bye.